So we're going to just go straight on to the next session. We've got a wonderful group of speakers. So if I could just start, where's Rick gone? There he is, yeah. So great pleasure to introduce Professor Rick Steeds. Probably doesn't need any introduction, but he's a consultant in Birmingham, where he leads the metabolic cardiomyopathy unit. He's a professor at the University of Birmingham, I think well known to all, but particularly important is the fact that he's actually meant to be in Bruges with his wife at the moment. So we're all going to have to club together so he can get the chocolate and flowers. But I think because of that, he's going to rush off after his presentation to get a later train. So we'll ask him some questions at the end rather than the panel at the end. So thank you very much, Rick.
Thank you. I am rushing off because I'm very worried that my wife might have spent up on the shopping trip this afternoon. So Fabry disease, for those of you who don't know, is an X-linked inherited defect in the GLA gene. What that means is that there is a failure in enzymatic conversion of glycosphingolipids and lyso-Gb3, and that accumulates within the lysosomes of cells and creates these typical zebra bodies that you can see in this renal biopsy on the right-hand side. It's important just to mention it's X-linked. So I think in history, it has been thought that women don't fare so badly out of Fabry disease as men, but that's not true because of a series of processes called X inactivation. And it's heartening. I went to a meeting with Amicus talking about the long-term results of Follow Me, which is a registry of follow-up from migalastat. But there is a hangover from that. So women are very much less likely to receive treatment. They are very much less likely to be diagnosed with Fabry cardiomyopathy. So it's worthwhile understanding that X-linked doesn't mean any inequality in impact on women compared to men. There are two forms. These are divided up. So mostly nonsense, missense, and premature stop codons create a complete absence of the enzyme. And that creates the traditional multi-organ disease of Fabry. So it tends to occur within multiple organs and it impacts people around 50 if they're men and 60 if they're women, but earlier. If you look at this diagram here, these are people with classical Fabry disease, and their men are starting to appear to develop left ventricular hypertrophy. Most have got it by the time they're around about 30, and women tend to get it a little bit later. Non-classical pathways are those ones where there's some residual activity. So this is a later onset form where you tend to get single organ involvement. So it was originally described as a cardiac-only variant, but that's not entirely true. They're usually minor variations in other organs, but it tends to happen much later. So in this group, you would tend to get left ventricular hypertrophy in about 60. And you can see women do the same, but they do the same about 10 years later than men. Same thing, if you look over here in terms of mortality, you'll see that men with classical disease die sooner than men with non-classical disease. Women die a bit later than both, but they still die earlier if they've got classical disease compared to non-classical disease. When I asked my colleague Will Moody what I should tell AICC clinicians, he said, oh, well, mainly, how common is it? Do I really have to bother about it? And how am I going to miss it? So this is how common is it. The most important thing is that there are two studies looking at neonatal screening, mostly using GLA activity, that identify disease in around somewhere between 1 to 5 in 10,000. But actually, if you look at prevalence rates from community studies or family screening, then actually prevalence is lower, and it's somewhere between 1 in 40 to 1 in 100,000. So that tells you something else. We treat women badly, but we also miss the diagnosis a lot. And that is exactly analogous to what patients tell us. So on average, patients have developed some symptoms about 15 years before somebody comes up with a diagnosis. On average, patients with Fabry disease see 7 or 8 physicians. So we can talk about the additional extra cardiac signs or red flags in Fabry disease, which is a common talk, but we're not picking up on that. You can look at enriched populations. On the right-hand side, there is a study from Austria where they looked at everyone who'd undergone dialysis, and they did blood spot analysis, and they came up out of just over 3,000 dialysis patients, a pickup of 4 positive Fabry disease patients. Cryptogenic stroke, again, is a study with a pickup rate of 1.2% if you look at cryptogenic stroke in the ages of about 40. And this data from late onset HOCM gives a rate of 3 to 6%. But actually, it's interesting, the number of people that I see who run specialised hypertrophic cardiomyopathy clinics who say, well, I've been screening everyone for ages and I haven't seen any patients with Fabry disease. And so I think this is a situation where it's probably overestimated. Being a simple cardiologist, I've always thought, well, if it's inherited and it's X-linked, you really ought to be able to just identify people through screening because you have index cases and we should just be able to do it if we do this really well. And I've been in the service for about 12, 15 years. And while I was there, my colleague wrote the guidelines for Fabry management and introduction of therapy. And as part of that, it was written in the guideline that we have to have a visible pedigree so that all clinicians should look at the pedigree and be able to ask at every single contact about whether or not the relatives have been screened. And I've just got some funding to employ a genetic assistant directly embedded within our service. And it's interesting. And it's rather hearkening. So I've spoken back to Dr. Hewat and said, actually, well, we don't have identified pedigrees in 88 out of our just about 100 patients. And so we don't do this very well. And when I talk about it in our department, everyone seems to think that it was somebody else's job. And as in the NHS, usually when it's somebody else's job, it means that nobody's doing it very well. It's true also that out of the number of probans, a number of relatives at risk, 715, the number with evidence of contact is 298, and out of that, 181 have been diagnosed. Now, the other thing that I think is really worthwhile, and it's something that we're fixing on at the moment, it's a bit of discussion in the Fabry community, sorry, I didn't mean to go forward, is that actually out of those people, almost all of our patients are Caucasian, white Caucasian, and a lot of them are quite middle class. And I think that there may be barriers to screening. So we have only 7 patients with South Asian ethnic origin. And look, we've been looking at that group in detail. And 5 out of those 7 were diagnosed on renal biopsy. So they're very late presentation. So there is something that means that we have very limited ability to screen in non-Caucasian populations. And actually there's the same socioeconomic difference in who we see. But actually family screening at the moment, I think, and we're not alone, looking to the other 3 treatment centres in the UK, this is a similar shared experience. So there are a lot of people out there who haven't been diagnosed and don't rely on family screening existing services to make that diagnosis happen. This is a great paper for anyone who really wants to know about Fabry cardiomyopathy by Pieroni, which was published in JACC a couple of years ago. And the take-home message from this is really one thing, which is that Fabry disease is slow, gradually accumulated, and it gradually is like a slow train coming because you're going to get the disease in the end and everybody pretty much gets the disease. What I think is important for Will's comment is to say, what are the flags? Because by the time you've got end-stage disease, which I'll talk a bit later, you will identify it and you will pick those up. But what you really need to think about are the people that are a bit odd, and maybe even before they've got left ventricular hypertrophy, and I'm not talking extreme left ventricular hypertrophy. So myocardial dysfunction, patients with Fabry disease have low GLS, and if you have really good quality GLS, they have reduction in GLS in the infralateral wall before they get late enhancement. They get chest pain and arrhythmias. So this is a lady, 59, classical mutation, central retrosternal chest pain, precipitated by exertion, lasting 5 to 10 minutes each episode, relieved by resting. She's got angina. She's short of breath when she had pain, but she didn't notice anything else. She's got a bunch of things which other Fabry patients get diagnosed with. Fibromyalgia is really common. I ache all over. I have some burning in my legs. And I get funny bowel habit, which is a classical non-cardiac symptoms with patients. She didn't have any risk factors. She'd been in hospital about 15 times over 7 years. She'd had 3 invasive coronary angiograms and 2 CTs, and the last one was 3 years before, which was normal. And she always ended up with this angiogram because she came in and she had a slightly abnormal ECG with a troponitis. And so that's something I would say was a real red flag for early involvement. And as I said, troponin tends to start to be released in these patients even before, in some of them, before they get left ventricular hypertrophy. ECG changes is something that's supposed to happen early. So we know that sphingolipid is deposited in most patients in their conduction system of the heart, right from birth. So one of the earliest changes that you happen is PR shortening, but then it starts to elongate. So something about the lipid deposition means that you conduct much faster, and your QRS tends to get narrower, and your PR interval tends to get shorter. Then you start to get a bit of bundle branch block. So this is this lady's ECG. It's another reason why she had an angiogram, because she had an RSR complex N V1 and V2. But actually, by the time you get late disease, you don't need to be a rocket science to think that there's something very odd if this person's got a troponin, and you know where they're going to end up. Transthoracic echo is a great technique. I think, again, the problem is that when you think about left ventricular hypertrophy, so this is one of our patients with a classic mutation, the wall thickness is 12 millimeters, but we've all been educated about our accuracy at measuring. So Gabby Kaptur took me to one side and asked me to measure 20 or 30 echoes at an international meeting just after Petros Neonopoulos had been asked to measure wall thickness. And I was acutely aware that I might not be measuring it in exactly the same place as everyone. And actually, between the experts in her paper, it suggested that experts vary in their wall thickness measures by up to 4 millimeters, which is astonishing. 12 millimeters is the cutoff in Fabry disease for introduction of therapy. There's a lovely paper recently from a shared multi-center Italian group here, which summarizes the progression on echocardiography in Fabry disease. So it starts off, most people, young and female, when you've got a normal heart, you start to get changes in GLS and E prime before you get left ventricular hypertrophy. Then you start to get left ventricular hypertrophy. Then, of course, inevitably your LVDP goes up, your left atrial volume increases, and then ultimately you go into elevated LVDP identifiable by E over E prime above 15, or a TAPSE, maybe RV involvement. Isolated RV involvement is quite unusual in Fabry disease. Left atrial enlargement, I think, is a real bugbear. Patients with Fabry disease have a very high rate of stroke, somewhere around about 11%. And I'm sure that direct sphingolipid deposition in the atrium contributes to this atrial enlargement, but LA strain is an early change also in this group of people. And I think we will probably hear more about that in the future. Once you've got the lady who comes in with chest pain and you think, well, her troponin's up and she's got a really odd ECG, you know where she's going to go. She's going to go on the magnet, and she's going to have late gadolinium, and she's going to end up with a finding like this. So she's got left ventricular hypertrophy, and she's got this rather diffuse, I don't think it's just that we're crap at MRI in Birmingham. This is typical appearance. It's just a little bit grey. It's not standout gadolinium, but it's located in the basal infralateral wall, exactly where you get altered strain. The issue is that you really ought to, and it's part of our standard LVH protocol or bundle branch block protocol, you just do one mid-slice T1 map. And if you have Fabry disease, T1 lowering happens before you get left ventricular hypertrophy in men, and then very much you get late gadolinium in men after you get left ventricular hypertrophy. It's worthwhile remembering in women, you get T1 lowering in women, and you can get late gadolinium enhancement before you get left ventricular hypertrophy, which is just a slight caution. Your T1 values are of the order of 8 to 900. They're not borderline, they're properly low. But the only other caution is that we do a base, mid, and apical short axis, and we do a global T1 and look at each of the segments. And actually, you find quite patchy lowering of T1, and of course, you get pseudo elevation of T1 in the basal infralateral wall. Diagnostic triggers. So on the left-hand side, I've put my thought about. So this is something I think is common, is that we're saying, right, okay, well, Rick, you've said it's common and we missed lots of it. And we said, you know, there are some atypical presentations you need to look at for early. What else do you need to look at? And they're not, you know, when was the last time as a proper cardiologist you got somebody to take their pants down? Well, I haven't done it very often. But unfortunately, you end up missing the classic angiokeratosis that you see. And it's difficult. I know it's difficult because if you look up here, of course, the commonest reasons we see left ventricular hypertrophy at 12 millimeters is because people got hypertension, because they maybe have a bit of valve disease, maybe they're athletes, but actually Fabry disease comes right down at the bottom. It's in the bottom 2% of potential causes of left ventricular hypertrophy. So actually it's somebody with some rather non-specific ECG changes, a bit of troponin elevation, some very mild LVH, and then you've got to send them to the magnet, and then you want to look for late gadolinium, and you want to look for T1. So T1 should be part of your protocol. And of course, always do a urine dipsticks and look at the creatinine if they've got a bit of LVH. Laboratory diagnosis, this is taken from the ESC guidance, but it's the same, and it's exactly the same as what's usually recommended. In men, you can usually get away with GLA activity. It's just a simple 5 ml sample, goes to biochemistry. It's not complicated, and you can get a sample, and if the GLA activity comes back in men, you can forget all about it. Now, in men, if it's a bit low, they will go on and have single gene sequencing in everyone, because we do gene sequencing in everyone. In women, it's slightly more complicated, as always, that you can get low GLA, but you can get relatively intermediate levels. So in women, you need to go on and do genetic analysis anyway. There are some variants of uncertain significance. We've just embarrassingly had a person who has been under our care, who's 58, classical Fabry disease, but with variant of uncertain significance. We thought that he had some T-wave changes, and then he dropped his T1, and we put him on enzyme therapy. He's been on enzyme therapy, we've been monitoring him, and his T1 has gone back into normal range, and his ECGs have resolved, and we realised actually that there were some errors on his T1 map, because we had a period of time when our T1 mapping sequence changed without our knowledge, and we've just stopped therapy after about 5 or 6 years, and I think just about £500,000. So be careful of variants of uncertain significance. Therapy. I'm not going to talk about therapy, but this is a real bugbear of mine. So one of the reasons I'm doing a project in family screening is we have a family of 10, all of them 10 brothers from Nottingham, and they have all started to come to our clinic because they went to a funeral and their brother died at the age of 58, and they've progressively come in sequence with advanced cardiomyopathy with a variety of symptoms, having been diagnosed with fibromyalgia, irritable bowel, and a whole host of things. This gentleman wasn't part of their family, but he's quite typical of people coming into the service. So he was referred in 2019. He was short of breath, managed 200 metres on the flat. He'd had quite a precipitous reduction in his exercise capacity, and was cycling to work a couple of years before. He was a teacher. He had typical angina, and he had been under long-term follow-up in tertiary care for a hypertrophic cardiomyopathy clinic. And it's difficult, as in 2013, there, but for the grace of God go I. He presented following a traumatic road traffic accident. He was assessment, he had an abnormal ECG, had severe LVH. He had initial diagnosis with an MRI of hypertrophic cardiomyopathy, didn't have T1 mapping, of course. Then he developed coexisting chronic kidney disease, renal biopsy flagged up, Fabry disease. So he came to us, and his first words to me in clinic were, in 2019, I want to get back to work. I want to live long enough to see my teenage daughters go to university. At that stage, he had severe left ventricular hypertrophy, wall thickness 19 millimetres, LV mass around about 300 grams, extensive late enhancement. He had a dynamic LVOT gradient, so we treated that to see if it could improve his symptoms, stopped his candesartan, beta-adrenergic receptor antagonist, gave him a slow-dose diuretic to improve his shortness of breath. For chest pain, it's very difficult in Fabry disease. It's mostly microvascular. We double-checked his CT, coronary angiogram, but there was nothing on it. We put him on ranolazine, which seems there's some very small studies suggesting it's a bit better. Disease modification, there's pretty wide consensus that enzyme replacement therapy or oral chaperone therapy do not work. And so this gentleman was not started on anything. We started to talk about kidney transplant for him. His symptoms were all cardiac. But he had advanced renal disease, so he was up for a kidney and a cardiac transplant. It became increasingly difficult. He had multiple episodes of non-sustained VT. He had an ICD, but he died with refractory VT 2 years after diagnosis. So that's, I think, quite brutal. And I think that's really brams it home to me why I'm quite evangelical about early diagnosis and screening. And this is a paper by Ravi Vijayapuru, who was my research fellow who's in the audience. And it's just longitudinal CMR data looking at the efficacy of ERT. So ERT and oral chaperone therapy have echocardiographic data with the primary endpoint mostly looking at as a secondary outcome measure compared to renal function. So there's no question that these drugs and therapies have made a difference to life expectancy and presentation of patients with Fabry disease, but it seems to work better on the kidneys than on the heart. And if you look at our data, it suggests that enzyme replacement therapy doesn't stop progressive changes over 8 years in our patients. It's interesting to think about whether it might do early in disease, and actually that's what most of the push is, to try to look and design studies in people with early disease. There was a hint in this study that maybe you could reverse T1 lowering in women on enzyme replacement therapy, but I think that's just subgroup analysis in difficult patients. So early treatment is actually the name of the game in Fabry disease at the moment. So Fabry disease is rare. You aren't going to see it very often. So Dan Sado at BSCMR came up with a lovely thing. He was the author of that paper on T1. He said, I spent 3 years of my life doing my PhD. I now run a cardiomyopathy clinic in London. I haven't seen a single bloody Fabry patient. So it's not that common, but family screening is not good, and you do need to be aware. High-risk people coming to you with kidney disease and slightly funny symptoms are important. Age and sex are important. Men, classical disease, think about a 30-year-old with LVH. Women, 40-year-old with LVH might have classical disease. And think about their strain patterns and troponin. ECG echo and high-sensitivity troponin can give you, but you've really got to be on your mark. And cardiac MRI is useful, but actually it's worthwhile thinking about adding on a T1 map to your standard LVH protocol. Most of my patients start to become symptomatic from 30s and 40s. We give them SGLT2 inhibitors and standard therapy. They are starting enzyme replacement therapy, but I think more work needs to be done in that area. And then we really don't know what to do with the people with advanced disease. Thank you very much.
Thank you, Rick. A wonderful talk, and do thank your wife for allowing you to talk to us, our benefit. Great. Any questions from the audience for Rick before he has to rush off? So Rick, I haven't got many Fabry patients, but they often look like they've got characteristic facial features. Do you think that's a real thing?
I am not aware of anything. After I started to think about this issue about ethnicity and diversity, I've been fascinated, and I don't know whether it's just because of a willingness to screen or otherwise, but it is astonishing that quite a lot of them are well-to-do, they're intellectually reasonable performers. You know, the Nottingham guys, a mixture of gardeners, but run their own business and do a variety of things. Facially, no, I haven't seen that.
Lima.
Presented. Did you also look at how many of them had exon activation, and that might have been a cause for why they presented?
So the honest answer is that the link between genotype and phenotype is really complicated, and you don't see any direct correlation in Fabry disease. And I think it's extraordinary. I do not understand it, but some people in the same family with the same mutation have widely different phenotypic appearances. Some people have absolutely gross left ventricular hypertrophy, extensive scar, and other people seem to be perfectly okay. It's very, very bizarre. Yes. I do think, interestingly, I'm strongly of opinion that the gentleman who did the last abstract, I'm really interested. I'm quite obsessive about trying to get my Fabry patients to exercise and keep fit, because I'm sure that keeps them better for longer. And I'm quite convinced that actually the people with the worst phenotype are the people who have coexisting stimuli. So if they've got kidney disease and they've got Fabry disease, the Fabry disease who don't get the kidney disease, they have the guys who have the kidney disease end up with much worse hypertrophy. And I think they're interactive environmental stimuli.
There's a question from online. At what age should clinical cardiac screening be started in children diagnosed as carriers of Fabry disease, marked by cascade genetic screening? Which tests and what frequency?
Oh. Okay, I'm going to skip that because I'm an adult cardiologist.
Do we have Esther in here? Would she like to comment, or Juan? I don't know whether you're... Can't see. Any comments, Juan?
it's a really difficult area, isn't it? And I don't think we have sort of enough data yet to show. I think sort of clear morphological manifestations of left ventricular hypertrophy are exceedingly rare in the pediatric population in boys. I think we possibly have, a couple of teenagers where once you start looking, you sort of start seeing some early features, but I think it's extremely rare. But I guess the question is whether pre-phenotypic identification and therefore earlier onset of treatment is a good, it's a good enough rationale for screening at an earlier stage. But we just don't have data on that.
I think that goes to the heart of the issue, is that actually we probably don't identify. By the time you've got left ventricular hypertrophy, you're already getting into a situation where we think that therapy may be ineffective. The problem is that we don't have the data to support early initiation, but there's quite a swell of agreement within the metabolic community that early treatment can be justified if you find signs like changed GLS and things like that.
So I was just going to make a brief comment with Juan and to say that in the pediatric population that we screen for Fabry, we're not really looking for a cardiac phenotype initially to start treatment. That's not really what I would recommend you should screen pediatric patients for. So our inherited metabolic team, I run the Fabry service in Northern Ireland, and the inherited metabolic team screen them quite regularly for symptoms and school attendance and pain and those sort of features, and then would have a low threshold to offer therapy based on that, but not so much the cardiac phenotype.
Great, thank you. Well, thank you, Rick. We better let you get your train, or we'll be in even more trouble.
I'd like to welcome our next speaker, who's Professor Robert Pitceathley. I hope I got that right. I've been rehearsing it in my head for 100 times. He is Professor of Clinical Neurology and Mitochondrial Medicine at UCL, and he is the co-lead for the nationally commissioned Rare Mitochondrial Disorders Service based at the National Hospital for Neurology and Neurosurgery. And he's going to talk to us about mitochondrial disease.
Thank you very much, and I'd just like to start by thanking Rachel and the organisers for inviting me to come and speak to you today. So hopefully this will be of interest to you and also clinically relevant. So just by way of overview of my talk, I'm going to start by giving you a brief recap about mitochondria and mitochondrial genetics. I'm going to shape the talk so that it's relevant to cardiac disease and mitochondrial diseases. So I'm going to talk a little bit about mitochondrial DNA testing specifically for cardiac disorders. And then finally, I'm going to finish on some emerging therapeutic strategies which are really being developed broadly for primary mitochondrial diseases, but I do think there's going to be an opportunity for these to be extended into more common diseases in which mitochondrial dysfunction has been implicated, including cardiac problems and heart failure, for instance. So this is a mitochondrion. This is how they're often depicted in textbooks, but of course, this isn't how they really exist in real life. They're incredibly dynamic organelles. They're constantly fusing and dividing, exchanging genetic material and communicating with each other in order to meet the metabolic demands of the cell. But this is quite a useful depiction of a mitochondrion. So they do have two membranes, an outer and an inner mitochondrial membrane. The inner mitochondrial membrane is highly convoluted, and that enables its surface area to be very large so that all these important metabolic pathways and enzyme reactions can take place. And mitochondria, because they are the cellular hub of metabolism, have been implicated in all sorts of acquired and genetic diseases, rare and common. But the one that I'm going to focus on today are primary mitochondrial diseases. So these are, in essence, genetic disorders that affect the ability of the mitochondria to produce ATP, the cellular unit of energy. But it's important to remember that mitochondria do a lot of other stuff apart from energy production, but that's going to be the focus of this talk. So this is what I'm talking about. So the reaction is called oxidative phosphorylation, and I'm sure you'll be familiar with that, but just to review, essentially it's electrons derived from food that are then transferred sequentially across a series of enzyme complexes. And these enzymes are embedded in the inner mitochondrial membrane. And these redox reactions that take place as the electrons are transferred across these complexes produce some small amount of energy, and that allows the translocation of hydrogen ions, so protons, from the mitochondrial matrix into the intermembrane space, so the space between the inner and the outer mitochondrial membrane, thereby setting up an electrochemical gradient across the inner mitochondrial membrane. And that gradient is harnessed by the terminal component of oxidative phosphorylation, an enzyme called ATP synthase, or complex 5. The hydrogens flow back into the mitochondrial matrix along that electrochemical gradient, and ATP is formed. So, as I've mentioned, primary mitochondrial diseases are genetic diseases that impair that process, that energy-generating process. But actually, the more we learn about the genes that cause mitochondrial disease, the greater that definition becomes. And so any genetic disorder that affects mitochondrial structure or function could be considered a primary mitochondrial disease. And these are relatively common. They're considered rare diseases, but within that group, they're relatively common. So in adults, we think at least 1 in 4,300 people have a mitochondrial disease. But the carrier rate for pathogenic mitochondrial DNA variants is much, much higher. So 1 in 200 people are thought to carry a pathogenic mitochondrial DNA variant. That's not to say those people have symptoms related to that, but they do have the potential to go on later in life to develop symptoms or transmit that mitochondrial DNA mutation to their children. It's important to remember primary mitochondrial diseases are caused by mutations in 2 separate genomes potentially, both the mitochondrial DNA that is within the mitochondrion itself, but also the nuclear DNA. So there are around 1,500 nuclear genes that are thought to be important for mitochondrial function. In the case of mitochondrial DNA, there's an important concept known as heteroplasmy, which I'll expand on in the next slide or two. Mitochondria are ubiquitous, so they're present in every cell in the body producing energy, and so often what you see, particularly in children, is multi-system disorders. And that's why they're often considered quite complicated, because you have multiple organ involvement and it's often difficult to connect them, but it's mitochondria that are the connection. But actually in adults, we often see tissue-specific presentations, so particularly CNS and neuromuscular disorders. And that's partly why neurologists, specifically in the UK, do tend to run clinics for these patients. And it's important to note that cardiac manifestations are a relatively common feature in primary mitochondrial diseases. So in children, up to 40% are thought to develop cardiomyopathy. So this graphic just summarizes what I said. So each cell in the body contains hundreds to thousands of mitochondria. The higher the energy requirement of that cell, the more mitochondria it has. Each mitochondrion can contain multiple copies of this circular genome, mitochondrial DNA. And mitochondrial DNA is only 0.1% of your genome, so it's 37 genes versus 20,000 genes in the nuclear genome. And those 37 genes comprise 24 genes, so R and tRNAs involved in synthesizing 13 protein coding subunits. And those 13 protein proteins form subunits of these complexes that are involved in ATP generation. And as I'm sure many of you are aware, one important property of mitochondria is that they're maternally inherited. So if a mother has a pathogenic mitochondrial DNA variant, that will be transmitted to all offspring. What you can't predict is how much, and again, I'll come on to that. And so there are some important characteristics of mitochondrial DNA that is useful to be aware of when considering these diseases. So the first, as I've mentioned briefly earlier, is heteroplasmy. So this occurs because you have hundreds to thousands of mitochondria in every cell in the body. So what you can end up with is a mixed population of mitochondria in a single cell or a single tissue. So some that harbor a pathogenic mitochondrial DNA variant and some that are wild type. Most pathogenic mitochondrial DNA variants are heteroplasmic. That is, there's this mixed population of mutant and wild type mitochondria, but occasionally we do see homoplasmic mitochondrial DNA variants. So that is that all of the mitochondria carry this mutation. And a very good example that's relevant to cardiology is the 4300 variant, which is present at homoplasmic levels in every tissue in the body, but for some reason expresses itself only in the heart and causes cardiomyopathy. But there are other examples of these homoplasmic variants that do manifest with tissue-specific features. Another would be Leber's hereditary optic neuropathy. Heteroplasmic levels, those mutations that are heteroplasmic, they can change over time. And one good example, again, that's relevant is the 3243 mutation. So when you measure that mutation in blood, you see it reduce over an individual's lifetime. And the reason for that is because blood is a rapidly dividing tissue, and there is a negative selection pressure against the mutations so that it reduces to the point that actually often in later adulthood, when people can present with this mutation, you can't detect it in the blood at all. That's not to say it's not there. It is there in the body. It's just not there in the blood. And what we've found is that you can actually detect it in epithelial cells. So we'll often ask for a urine sample where you can actually extract DNA from the urinary epithelium, and we can usually find it in that. But if we can't there, we have to do a muscle biopsy, because obviously muscle is a post-mitotic tissue, and we can be absolutely sure that the mutation is retained there. The other important concept to be aware of with mitochondrial DNA specifically is the threshold effect. So there is a biochemical threshold that exists whereby the number of mutant mitochondria reach a certain level and you develop symptoms. So the cell fails, not enough energy, and you develop symptoms. And generally speaking, mitochondrial DNA-related diseases are recessive. So you need quite a high level of mutant mitochondria before you reach this threshold. But that threshold, and that's typically 60 to 70%, but that threshold can change according to the tissue and according to the type of variant you have. So we do see some mutations where they're extremely recessive. You won't see anything until you're at 90%, other mutations at a lower level. And we do have recurrent features clinically where there seems to be vulnerability. So for instance, the heart, the brain, the skeletal muscles, which we assume is because there is a lower threshold. And finally, the final concept it's important to be aware of is this bottleneck that exists. So what you often find, and is what is very characteristic of this group of conditions, is a discrepancy in the symptoms, both between mother and child and also between siblings. And partly that's explained by a bottleneck that occurs during development of the eggs. So typically, an ovum will contain around 100,000 mitochondria, but that level is restricted to just a couple of hundred in the primordial germ cell. And so just through completely random segregation, if you pick a handful of mitochondria here, here, and here, you may end up with a variable number of mutant versus wild-type mitochondria. What then happens is this rapid amplification of those mitochondria, and you end up with mature eggs with a very variable number of mutant mitochondria within them. And so if you're unlucky and this egg gets fertilized, then you'll have a high level of mutation and quite a severe phenotype or a miscarriage. If you have a lower level or an intermediate level, you'll get a completely different situation. And that's why within families, you often see a different level of the same mutation associated with milder or more severe phenotypes. So mitochondrial DNA is DNA, and so it can mutate, and actually it has a very high mutation rate, and that's partly because it sits within the mitochondria very close to the electron transport chain where lots of reactive oxygen species are being generated, and those are damaging. And unfortunately, mitochondrial DNA doesn't have very good repair mechanisms, unlike nuclear DNA, and so can't repair these double-stranded breaks. And it's also not protected by histones, as you see with nuclear DNA. And so since the first mitochondrial DNA mutation that was linked to mitochondrial disease was described in the late 1980s, over 250 pathogenic variants in this very small 16,500 base pair molecule have been described. And what you often see is them referred to by their nucleotide position around the circle. So if you imagine you start at nucleotide 1 and you go around in an anti-clockwise fashion, you end up at nucleotide 16,500. That's where that's how you label the nucleotide around the circle. And so this is where 3243 would sit. This is where 4300 would sit. Just to finish, in terms of genetics, it's very important to remember that mitochondria are under dual genomic expression. And so although I spent all that time talking about mitochondrial DNA and how important it is, and indeed it is very important, particularly in adults, because we think probably 70 to 80% of adults have a mitochondrial DNA mutation underpinning their primary mitochondrial disease. There are 1,500 nuclear genes that are nuclein coded, and of those, over 400 have been associated with primary mitochondrial diseases. These are much more common in children and tend to be associated with more severe phenotypes. And so what about primary mitochondrial disease and cardiac phenotypes? Well, I don't want to spend too much time on this because I appreciate the next speaker is going to be talking on this subject, but there are a wide variety of manifestations, cardiac manifestations in primary mitochondrial diseases, ranging from cardiomyopathy to cardiac conduction defects. Hypertrophic cardiomyopathy is arguably the most common, but a number of other subtypes are described. These are progressive diseases, and we don't have a full understanding of the prevalence of these and the natural history of these across all the different types of primary mitochondrial diseases. And so we have a fairly belt and braces approach to screening, and we do screen most patients for cardiac manifestations of primary mitochondrial disease. One important feature of these is that they can deteriorate during metabolic stress. So if you do see someone who's admitted with heart failure after a viral illness or some sort of physiological stress, then consider mitochondrial disease. So moving on to mitochondrial DNA testing for inherited cardiac disease. So I'm not going to spend any time on general genetics in mitochondrial disease and how we do that. I'd rather focus on mitochondrial DNA genetics in the context of inherited cardiac disease, just for time. So this is something we've developed with colleagues at Barts Hospital, and this is really just a pathway to try and avoid overlooking mitochondrial DNA variants, particularly the 3243 and 4300 mitochondrial DNA variants as a cause of inherited cardiac disease. And so I'd be happy to share this with anyone who would like it. So if you have someone who has features of primary mitochondrial disease, some of which are listed here, then you could go straight to screening for these variants. And this is both in blood, so the 4300 mutation, because it's homoplasmic, you retain that in blood throughout your lifetime, and so you can always detect that in blood. But the 3243, as I've mentioned, reduces over time, and you may overlook that, so we ask for urine as well, and if that's negative, then we would offer seeing the patient in our clinic, and we would sequence the entire mitochondrial genome, because within those 16,500 base pairs, there are many causes of cardiomyopathy, but they're much, much rarer. And so we would go on and sequence the mitochondrial genome from blood, and then if that was still negative, we would go on to do a muscle biopsy because we don't want to overlook a mitochondrial DNA mutation. So ultimately, we have to do that to exclude. If there aren't these features, then obviously you would continue to do normal cardiomyopathy genetic panels via diagnostic molecular diagnostic laboratories, and if that's still negative but you are still concerned there is a genetic cardiac problem, then we would recommend screening for those specific mutations. One point I just want to make on mitochondrial genetics are some of the ethical implications around testing for mitochondrial DNA, because mitochondrial DNA isn't just a diagnostic test, it's also a predictive test. So for example, if you had an example like this, a 28-year-old woman, mild deafness and cardiomyopathy, and so you were considering 3243 and you find that they do harbour that is a diagnostic test for the deafness and cardiomyopathy, but it's also a predictive test potentially for that individual subsequently developing a more severe phenotype in later life. And that could include diabetes, renal disease, seizures, stroke-like episodes, and dementia. So it's important to consider this when counselling the patient because that's something that's important to mention. And we try and do that through a record of discussion. And it can be very challenging because although there is risk, it's very difficult to quantify because we can't measure the levels, for instance, of 3243 in the brain. And so we can't really accurately counsel patients as to the likelihood of them developing these more severe phenotypes. It's also important to remember there are diagnostic and predictive implications for other family members, because unlike Mendelian genetics, if you have a mitochondrial DNA mutation, there is going to be maternal transmission to all offspring. And so there are potential implications for children, for siblings. There are going to be implications for having further children in terms of reproductive options, and also the wider family. So the final part of my talk is emerging therapeutic strategies for this group of diseases. And as I say, some of these do have implications in cardiovascular disorders. So a very quick mention, there's no good evidence for any treatments for mitochondrial diseases. We don't have any licensed therapies for primary mitochondrial diseases, although lots of vitamins, cofactors, food supplements and various diets have been suggested. None of them have been shown to be effective. And so a lot of what we're doing in the mitochondrial clinic is surveillance and early treatment of manifestations of mitochondrial dysfunction. However, over the last few years, there's been major interest from industry in developing treatments for mitochondrial diseases. And that's partly probably because of the incentives that exist for developing these treatments for rare diseases as orphan drugs. But also, in the case of mitochondrial diseases, if you can treat mitochondrial dysfunction, because of that slide that I showed you right at the beginning of the talk, these are such pervasive organelles involved in so many different pathophysiological processes and other common diseases, you could potentially then license that therapy for some of those much more common conditions. And so this is a couple of years old now, this slide, but you can see these are just some of the trials that are ongoing across mitochondrial diseases, some of which are at an early stage or in vitro stage, or preclinical stage, for some of these genetic therapies, but some of the at the stage of more late stage clinical trials in pivotal studies. And some of these treatments have taken the approach of a fairly generic effect. You improve energy production somehow, and it doesn't really matter what the underlying genetic problem is. If you can produce energy, you should be able to improve symptoms. Others have, and obviously there's a much larger market for those. Others have been much more focused on the underlying molecular mechanism, and therefore are more likely to be disease modifying, but you're targeting a much smaller patient population. As with lots of other genetic diseases, there's a lot of interest in developing genetic treatments for these conditions. The majority of nuclear mitochondrial diseases are recessive, and so using AAV as a vehicle to transport the wild-type gene into the nucleus where it's transcribed and subsequently translated in the cytoplasm is a way of getting wild-type protein into the mitochondria, and you do that by adding a mitochondrial targeting sequence, which all nuclear encoded mitochondrial proteins have, so that they know how to get into the mitochondria. For the primary mitochondrial diseases that have dominant inheritance, whereby the mutant allele is producing a toxic protein that's interfering with the wild-type protein, there are ways, obviously, as you all know, of targeting that mutant mRNA to abolish the protein. And more recently, there has been technology developed to actually manipulate the mitochondrial genome. So those previous slides were on the nuclear, were relevant to nuclear mitochondrial DNA, mitochondrial mutations. But there is now a technology to actually manipulate mitochondrial DNA. So up until recently, we've not been able to do this because nucleic acid can't get into mitochondria, and so CRISPR doesn't work. But there is now technology that allows us through bacterial toxins to actually target mitochondrial DNA through non-CRISPR technology. And so this has been, initially was published for C and G to T and A's, but now we've got A and T to G and C's in terms of the deaminases that have been developed. And so now we have the ability to manipulate mitochondrial DNA. It should allow us to develop better animal models of these conditions, which we've not been able to do, understand these mutations, how they segregate across different tissues, why they manifest in the way that they do, and hopefully correct them in the future. So just to summarise, cardiac complications are common in primary mitochondrial diseases, and they may be the only clinical manifestation. So please consider targeted mitochondrial DNA sequencing, particularly for the 3243 and 4300 pathogenic variants, and we're always happy to see these patients in clinic. There are a number of ethical considerations when you are screening for mitochondrial DNA. It's important to consider both the diagnostic and predictive implications. And despite any licensed therapies at the moment, there is still a lot that we can do in terms of surveillance, monitoring, multidisciplinary team support. And there is commercial interest in drug development in this space, and a large number of clinical stage studies ongoing, and a number of emerging genetic therapy approaches. So watch this space. And there I'll stop. Thank you very much.
Thank you very much, Rob, for a very comprehensive talk. Are you able to stay for the rest of the speakers with the panel?
Yeah,
Okay, we'll take questions at the end of speakers. Thank you.
Right. Well, moving on, it's a great pleasure to welcome Kostas. So Kostas Savvatis is a cardiologist at Bark, specialising in cardiomyopathies and all types of imaging, and an associate professor as well. So thank you, Kostas.
Thank you, Gerry, and many thanks for the invitation. It's a great pleasure to be here today. I'm actually very thankful to Rob, who's taken all the difficult parts of my talk away, so that I can just skip them and get everybody sooner to lunchtime. So in the next few minutes, I'm just going to talk about cardiac involvement in mitochondrial diseases, and as Rob has mentioned, is generally on most of the primary mitochondrial conditions, they are really maternally inherited, and due to mutations in the mitochondrial DNA, there are some nuclear DNA mutations as well, usually mostly autosomal recessive transmitted. And I think this is, we've seen it in Rob's talk. That's the important bit for us as cardiologists when we do see cardiac involvement, to think it as a multi-system disease. So these are the red flags that we have. Essentially finding cardiac involvement in patients who have various other systemic features and conditions, and always think about that. So this is, Rob has actually taken it pretty much away. So essentially this is the way mitochondrial work. We've got the heteroplasmy. Some mitochondria are going to be abnormal, some not, and clearly there's some of the homoplasmic, so I'm just going to skip very quickly. And in terms of pathophysiology, we think there's a tissue specificity, and as you've heard from Rob's talk, clearly this has to do a lot with how much the tissue load is, and this is part of the difficulty for us, because heart is very difficult to biopsy, and very difficult to see the tissue load there. Clearly, it's exactly as difficult for Rob to biopsy the brain and do that. So quite often we have to rely ourselves on the mutation load in either in the blood or on urine. There is, the theory is that there is mitochondrial dysfunction. Clearly, there will be a toxic effects from that. There will be sort of a fetal gene expression program and a lot of toxic products that will, and an abnormal reactive oxygen species that will lead to hypertrophy in the heart and dysfunction. Now, so Rob has mentioned a bit in his talk. So it's a bit of an interesting, primary mitochondrial disease and cardiac conditions are a bit of an interesting thing, because there is timely progression. We know these are progressive conditions that probably relate to the mutation load. So there is over the years a progression of that, and that will have to do with the LV mass and the fibrosis increase, and eventually to the systolic dysfunction. But one of the other important bits is that we can see very, very, very fast and very abrupt dysfunction in the heart, more so than in other heart muscle conditions potentially. And this can happen within hours and days, and usually happens when there is an acute mitochondrial dysfunction, lactic acidosis. And we often will see patients with cardiogenic shock, with a sort of stress cardiomyopathy, or potentially people that will come with a lot of ventricular arrhythmias. And there's clearly also this the decrease and increase in systolic function over weeks and months, and there have been publications, or have been case reports of patients that actually referred for heart transplantation. By the time they actually go to the heart transplantation, their cardiac function had recovered. Now, in adults, we've got about 30% cardiac involvement. So you can see here, this is one of the French group that looked into that in 2015. A relatively big population. That was the biggest one at the time, 260 patients. And I think that one of the most important things to remember when we're talking about mitochondrial conditions is, all around the heart. So they will have a lot of hypertension, probably higher than the general population. They will have dyslipidemia as well as diabetes, and these are, let's not forget about the cardiovascular risk factors for that. But specifically to the heart, we will see electrical system abnormalities, and at least some of those we'll get in a moment back to those, but also structural abnormalities. So usually the cardiac hypertrophy is relatively mild, but we will see some extreme cases. But what we will expect is usually hypertrophy in the area of 15 millimeters wall thickness, mostly concentric. It can affect the right ventricular wall thickness as well. In children, it's probably a bit higher, the cardiac involvement. Usually we see more extreme phenotypes, worse phenotypes, and mostly hypertrophic phenotypes are the ones that are going to be the most prevalent in the kids. Now, the interesting bit is that specific patterns, and we find probably because of that tissue specificity, we find some patterns more common in some mitochondrial conditions as compared to others. You can see here most of the mitochondrial diseases, they will have structural abnormalities, mostly hypertrophic in most of the cases, which can progress or can present even with dilated cardiomyopathy in fewer cases to start with, and very, very rarely there's a restrictive phenotype. In fact, actually, probably this specific mutation is the only one known that causes restrictive cardiomyopathy. And in terms of electrical abnormalities, usually they're going to be more common in the large-scale deletion cell. We'll see a bit more about that in a moment. And they usually consist of conduction disease, but we'll see pre-excitation, Wolff-Parkinson-White syndrome, and arrhythmias, both supraventricular as well as non-sustained ventricular arrhythmias, ventricular ectopics, are not particularly uncommon in this patient population. And this is on the left, busy slide. I don't want you to remember any of that, but on the left is it shows how variable the presentation and the syndromic presentation of the mitochondrial conditions can be. You can see quite a lot of the mutations can lead to different systemic presentation, but all of them, they will have some variable degree of cardiomyopathy and either electrical or structural abnormalities. So it's a helpful thing to remember when we're screening patients in clinic and to put a name to the cardiomyopathy. Now I'll focus a bit on the 3243 mutation, which is the most common mutation that we generally see. As we said, hypertrophic cardiomyopathy will be the most common presentation, progressive to systolic dysfunction. And this is one of the earliest studies in 2013 where they looked in a relatively small cohort for about 40 patients at the time, and they screened over various years. And actually what they found is that the events were pretty high. So from the time of presentation with hypertrophy on a median of 3.5 years, patients were developing heart failure and had potential cardiac events. And from the moment of LV dysfunction on the echocardiogram, relatively short time up until we have actually hospitalization or for heart failure or adverse events. And that seemed to be related to the tissue load, to the mitochondrial load, to the mutation load. And more important is probably going to be the urine that seems to be correlating better with the adverse outcomes, possibly as you've had from Obstop, because the blood load will change over time. So really, I think it's we can see that a mutation load above 45% seems to be correlating with adverse cardiac events in this, especially in this mutation. Now, this is a paper that came up quite a few years back now, but it did cause quite significant anxiety in the population, because it did describe a couple of cases of sudden adult death syndrome. It was the Newcastle group as well as some of our patients as well. And it did describe two patients and correlated that adverse outcomes with a mutation load. And I think that was quite an anxiety in terms of the cardiac population, how often we screen them. In terms of single large-scale deletions, so you can see here, we should see that more like a continuum, and progresses starts with a mutation, but it does seem that the degree of neurological involvement correlates also with the degree of cardiac involvement. And you can see if we have brain, inner ear, or retina manifestation, we have a very high degree of conduction defect and need of pacemaker, as well as progressive systolic dysfunction. And clearly, the earlier the onset of those manifestations, that was correlating with a higher degree of cardiac complications, whereas if presentation above 20 years of age seemed to be relatively good prognostic marker in this patient population. Now, these are the 2022 Heart Rhythm Association guidelines, and I've marked here what is important. Essentially, cardiac evaluation is recommended for all patients with primary mitochondrial conditions. And the easy bit is when patients present with a cardiac, with a high degree AV block, and that's the easy bit. We can decide they need a pacemaker, we know that. But I think this is probably the most difficult bit here, where it mentions that progressive ECG changes may actually lead to pacemakers. So this means quite often, as we see in the degree of cardiac conduction disease is relatively prevalent in this population. So we actually need to identify which patients are the ones that will benefit from a pacemaker implantation or need one, and decide that. And again, the French group looked in predictors of that back in 2015. The patient population have identified that risk of adverse prognosis are intraventricular conduction delays or conduction disease, essentially the presence of diabetes, hypertrophy, as well as premature ventricular contractions. And the more risk factors you actually have, the more likely you have to have an adverse cardiac event. So this is the most recent study that we're part of, and was published in 2022. And we looked into 600 patients with genetically confirmed primary disorders. You can see it had a relatively good median follow-up of 5 years. And the cardiac involvement and the events that we looked at were the heart failure events as well as the arrhythmia maze. And as you can see here, in about 10% of the patient population within these 5 years, they do have a cardiac event, which is a relatively high number. And half of them are going to be heart failure complications, so transplantation, heart failure admissions, death due to heart failure, and also arrhythmic events, which mainly consist of conduction disease, need of pacemaker, as well as sudden death. And I think this is one of the important slides, and shows, when we looked into genotypes, or the genotype plays quite significant role in the patient prognosis. You can see here when the groups were single large-scale deletions, the 3243 mutation, that was one of the most common one, and then the other point mutation as well as the nuclear DNA mutations. You can see here actually that the last two do pretty well over the time, from birth as well as from baseline of the cardiac investigations. But actually the ones that have the worst prognosis are really the single large-scale deletions as well as the 3243 mutations. You can see here the other interesting bit is that the single large-scale deletions tend to have early onset and significant events quite early on, so really in the late teens, whereas the 3243 mutation presents quite much older, in about the 4th or 5th decade with cardiac events, and that's quite important also for our follow-up in clinic. And the heart failure events are really more related to the 3243 mutation, quite, this decade that we see. And we can see that most of the heart failure events actually were related to 3243 mutation, whereas actually the other mutations in general had a relatively good prognosis on the long term in terms of heart failure presentations and events. And as expected, and as we know, the single large-scale deletion was really the most significant predictor of conduction disease, whereas all the other mutations generally had a relatively good prognosis in terms of conduction disease and need of pacemaker. And that was happening quite early on in the late teens, essentially. Now, when there's significant various risk factors that have been described, but here the genotype seems to be one of the most strong predictors for heart failure arrhythmia, so 3243 mutations, heart failure relation, and well as single large-scale deletion is really the ones that we should be looking in for conduction disease and pacemaker insertion. Clearly, the structural changes in the heart play a significant role as well, and developed a relatively simple risk calculator, if you want, or a risk factor or a risk score, where if you actually have the more risk factors you actually have, the more likely to develop one of those events. And that, I think, can be quite helpful both for our assessment in clinic, but also to define how often we see the patient, how we treat them as well. You can see here some of the findings, some of the baseline risk factors. The other important point is in going back to the original publication about the risk of sudden death in primary mitochondrial diseases, is that this seems to be more related really to conduction disease again. So this is something that we definitely need to address, and that probably seems to be the case, where ventricular arrhythmias are pretty rare, if any. Now, I've mentioned that there are some extreme phenotypes. Usually there is mild LVH, but you can see here this is one of the 3243 mutations. And in fact, actually, quite a lot of those populations are going to come, or quite a lot of those patients are going to come as a primary presentation to our ICC clinics. We may see them and describe them as a hypertrophic cardiomyopathy, a lot of fibrosis, very significant hypertrophy, very abnormal ECG. But in fact, there may be extreme phenotypes that actually are due to mitochondrial disease, and it's quite important that we pick them up because they do have different prognosis and different treatment. There are patients like that. Usually, we will see this abnormal hypertrophy in pediatric population, extreme hypertrophy, over 30 millimeters wall thickness and biventricular hypertrophy. These are very rare cases and probably cases that we should be treating on an individualized basis, not and not in a way that as we described in terms of risk factors. And as Rob mentioned, there's the 4300 mutation, which is the homoplasma mutation. For reasons that we don't quite understand, that it does have cardiac involvement. It has quite a profound and quite extreme, actually, cardiac involvement with a very typical and reproducible phenotype of lateral wall fibrosis, quite extensive, almost half of the ventricle becomes fibrotic, and clearly also these are patients that are very high risk in terms of heart failure presentation, potentially also sudden death. Treatment, as Rob mentioned, we're looking forward to having more advanced treatments. I think the take-home message, the important take-home message here is the early heart failure medication, potentially in patients with 3243 mutation who present with high risk factors as well, and prophylactic pacing in the single large-scale deletions when they have additional risk factors as well. I'll summarize here that cardiac involvement is common, is frequent, is about 30% of the cases, and the complications are generally heart failure related as well as conduction disease related. Ventricular arrhythmias are less common, not so common. The 3243 mutation is really the strong predictor for heart failure, and we should be quite aggressive in terms of follow-up as well as treatment in this population, as well as the single large-scale deletions, which are at risk of conduction disease quite early on in life. And quite often we, as adult cardiologists, we may not even be picking up them, so they will be coming in the pediatric clinics mostly. It's easy to do basic tests in clinic with a Holter, ECG, and an echocardiogram and identify high-risk patients depending on the genotype and some of the risk factors. And this will probably help us significantly in terms of follow-up and how often we need to follow up. For instance, if we've got a patient with no risk factors at all and a genotype that is not one of the malignant ones, then we can justify a less close follow-up in clinic. And as I said, the risk of sudden death in terms of ventricular arrhythmias is quite low. Always thinking on the conduction disease, though. Generally, ICD is not recommended. We would not recommend those in these patients unless we've got some of the extreme phenotypes as the ones that we need to be treating in an individualized basis. Finish here, and thank you.
Wonderful talk, thank you. We'll do the questions at the end, if that's okay.
So for our next talk, I'd like to welcome Professor Marianna Fontana, who is the director of the UCL CMR unit based at the Royal Free Hospital. She's also a professor of cardiology and honorary consultant cardiologist at the National Amyloidosis Center based at UCL.
Thank you very much for this invitation to speak. And so in the next 15 minutes, I'll briefly talk about ATTR amyloidosis, so from the diagnostic journey to the genetic testing and to the novel treatment. As you know, in many ways, the kind of beauty of ATTR amyloidosis is that it's a disease where the pathobiology is extremely well known. So we have a protein which is normally produced by the liver, the transthyretin, which under certain conditions misfolds and then deposits as amyloid into the different organ and tissues, causing a predominant cardiomyopathic phenotype in some of the patients, a predominant neuropathic phenotype in other groups, and a mix in a proportion of the patients. So how do we classify TTR amyloidosis? Based on the presence of a gene mutation in the TTR gene. So we have wild-type TTR amyloidosis versus no mutation in the TTR gene. is wild-type ATTR amyloidosis is emerging as an under-recognized form of heart failure, especially in the elderly. Has got a striking male predominance, although now we are becoming increasingly aware that this is probably also driven by our bias in our awareness of this being predominantly male disease. Is a progressive and fatal condition between 3 and 10 years, and there are extracardiac features that usually precede this condition of 10 to 20 years, like carpal tunnel syndrome or lumbar canal stenosis. After the age of 85, in 25% of the patients, we will have some amyloid deposits if we do autopsy studies, but amyloid deposits is a completely different entity from cardiac amyloidosis, which is the clinical syndrome associated with extensive deposits. Hereditary TTR amyloidosis is characterized by the presence of a mutation in the TTR gene, and it can present as a predominant cardiomyopathic phenotype, very similar to wild type, a predominant polyneuropathic phenotype where there is peripheral neuropathy and autonomic dysfunction mixed, but in hereditary TTR amyloidosis, now we know that the mixed phenotype is actually the much more common one. There is definitely a genotypic to phenotypic association, so there are more than 130 mutations associated with the disease, and traditionally we have been describing some mutations and neuropathic mutations like the V30 mutation, highly prevalent in Portugal, Brazil. So typically these patients present young with peripheral neuropathy and autonomic dysfunction. And there are mutations that have been traditionally described as pure cardiomyopathic, like the V122I mutations, which is present in up to 4% of Afro-Caribbean patients. However, now we know that actually when we assess patients on an individual level, the mixed phenotype is the most common one. As an example, if we take patients with hereditary ATTR amyloidosis associated with the mutation V122I, more than 50% of these patients will have coexisting neuropathy. And also the same mutations behave differently in different regions, like V30MET in Portugal behave very differently from the same mutation in Sweden. In Portugal, it's typically early onset. In Sweden, it's typically late onset in the predominant cardiomyopathy. But also the same mutations can behave very differently in the same family. So it's absolutely important to assess each patient at an individual level. How do we suspect ATTR amyloidosis? You are all aware of the cardiac and extracardiac red flags. And in terms of extracardiac red flags, of course, coexistence or neuropathy in a patient with an hypertrophic phenotype should raise the suspicion. Bilateral carpal tunnel syndrome is almost invariably present in patients with wild-type ATTR amyloidosis. Glaucoma, vitreopathies in hereditary TTR amyloidosis can be present. Of course, the family history on neuropathy in patients with cardiomyopathy. And also on the physical examinations, we find bicep tendon rupture, highly present in patients with wild-type ATTR amyloidosis, and weight loss related to autonomic dysfunction is extremely common in patients with variant amyloidosis. In terms of assessment, echocardiography is the first imaging modality that we all do in patients who present with heart failure symptoms. And what we typically see is concentric hypertrophy, which is actually very commonly asymmetric. 75% of the patients with ATTR amyloidosis will have an asymmetric hypertrophy. Atrial dilatation is almost invariably present, but the degree of dilatation is a bit disproportionate to the degree of the systolic and diastolic failure, because infiltration of amyloid within the atria stops extreme dilatation. It's very difficult to see severe dilatation in these patients. Typically, these patients have been described as patients with heart failure and preserved ejection fraction, but we know that ejection fraction is really not a good way to assess systolic function in these patients because the longitudinal contraction is usually typically severely impaired. From a diastolic point of view, usually they present with severe diastolic impairment, but even early impaired relaxation is not uncommon, especially in certain mutations like the T60A1, which is highly prevalent in Ireland. Pericardial effusion is an important sign because it is highly prevalent, especially in AL, but when we see an hypertrophic phenotype with pericardial effusion or pleural effusion, we should think about amyloidosis. As you all know, adding longitudinal strain adds specificity to the echocardiographic examinations because what typically happens is that there is a reduction in the longitudinal strain in the basal and mid segment with preservation of the strain only in the apical segment, and this gives rise to the typical bullseye appearance. But then how do we confirm the diagnosis? So traditionally we've been using the cardiac biopsy, but cardiac biopsy is really rarely done in the UK, especially in the UK, and really only end stage. So one could say, okay, let's do a screening biopsy. A fat biopsy is is not very useful in patients with ATTR amyloidosis because the sensitivity is as low as 15% in wild-type ATTR amyloidosis and is higher, 45% in variant ATTR amyloidosis. But if you think about confirming the diagnosis with a fat biopsy in wild-type ATTR amyloidosis, this will be useful only in 15% of the patients. The second problem that we hugely underestimated is actually how even finding ATTR amyloidosis with Congo red can be extremely challenging. We did an audit across the UK where we sent a stain slide with Congo red to different pathologists. And what we found is that the percentage of false negative results was as high as 1 in 4. And the percentage of false positive results was as high as 1 in 4. So in 1 in 4 cases, the pathologist will say, yes, amyloid is there, when amyloid is not there. And this is typically due to the white birefringence that we get with fibrosis that is often mistaken with the apple green birefringence that we get with amyloid. And the second problem that we found is that in 1 in 10 pathologists will fail to recognize the amyloid when the amyloid is there. So is the results that we get from cardiac biopsy always the right one? Not in a high proportion of the patients. Once we identified the presence of amyloid, let's say we overcome the first step, we need to type it. And typing is extremely challenging. It's usually done with histology and immunohistochemistry, but expertise is very important because the panel of antibodies that need to be used is very wide. And really nowadays, the gold standard is becoming mass spectrometry, but which is available only in one center across the UK. So histology is extremely complex in amyloid and requires high expertise. So how can we overcome the challenges related to histology? What completely transformed the non-invasive diagnostic pathway in the last kind of 15 years has been really imaging with CMR and bone scintigraphy. With CMR, we go back to the very seminal paper produced by the Brompton in 2005 when they described the very typical appearance with legal enhancement in amyloid. So CMR is extremely useful in the hypertrophy phenotype. So we have patients with an hypertrophy phenotype, and then legal enhancement will give pictures that are extremely typical of amyloid. At present, 60% of all the referral for TTR amyloidosis that are sent to the National Amyloidosis Center is because a local CMR is done. So CMR is now responsible for 60% of the referral across the UK. And very interestingly, a quarter of these CMR were done with no suspicion of amyloid whatsoever, but just usually query ischemia, and then the legat features raise the suspicion of amyloid. The second test that has completely transformed our non-invasive pathway has been bone scintigraphy. In the UK, DPD is the most widely used. So what we do, we use a bone tracer to look for any evidence of cardiac uptake. So grade 0, there's no cardiac uptake. Grade 1, 2, 3, increasing the bone uptake and decreasing the bone uptake. And you are all very familiar with this algorithm that now we use to confirm the diagnosis in more than 70% of our patients with ATTR amyloidosis. If we suspect ATTR amyloidosis based on echo, CMR, or clinical findings, then we proceed with the bone scintigraphy. And if we find the grade 2 and 3, cardiac uptake in the absence of a plasma cell dyscrasia, then we can confirm a diagnosis of cardiac ATTR amyloidosis without the need of any biopsy. And the only extra step that we need to do is TTR genotyping. But it's absolutely important to stress that to confirm the absence of a plasma cell dyscrasia, we need all these 3 tests. Blood and urine immunofixation, electrophoresis is not really good enough, and then blood 3 light chains. Is still incredibly high the number of occasions where cardiologists confirm the diagnosis of cardiac ATTR amyloidosis without having done these 3 tests. And it's absolutely important to reiterate that electrophoresis is not good enough. Blood and urine immunofixation has to be done. And still, in 30% of our patients, we need to perform a cardiac biopsy. So whenever we have a cardiac uptake, grade 2 or 3, but there is a plasma cell dyscrasia, we need to go for a cardiac biopsy. And it's absolutely important to recognize these. So when we need a cardiac biopsy, if there is a plasma cell dyscrasia, we cannot get away without doing a cardiac biopsy. using Congo red and then typing with immunohistochemistry and mass spectrometry. But then once we have confirmed the diagnosis of ATTR amyloidosis, how do we proceed in terms of treatment? In the last 10 years, the treatment landscape in ATTR amyloidosis has completely changed. When I started working with this condition 12 years ago, in clinic we would confirm the diagnosis, but we would say to the patients, there's absolutely nothing we can do. And now you will see we've got different treatment options in these patients, and I will focus on the patients with a cardiomyopathic phenotype. So it's not available yet in the UK, but now is available in Scotland, in Ireland, and will hopefully be available also in England, and is Tafamidis. Tafamidis falls within the class of stabilizers, and Tafamidis was approved on the back of the ATTRACT trial, which was done and published in 2018. So Tafamidis really changed completely everything because it was the first disease-modifying treatment that was associated with a change in survival of the patient. So Tafamidis met the primary endpoint with a reduction in all-cause mortality and frequency of cardiovascular-related hospitalization to month 30. And also the key secondary endpoint as KCCQ and 6-minute walking test were met with a decline in the reduction of the both 6-minute walking test and KCCQ as well. And this was a complete change for us because for the first time there was a drug that was approved to be given to patients with a cardiomyopathy and that would have dramatically had an impact on the patient's prognosis and quality of life. Very recently, also the results of the ATTRibute-CM study that test another stabilizer, the acoramidis, were also presented. So the results were presented at the ESC in Amsterdam this year, and the trial met the primary endpoint. The primary endpoint was a composite hierarchical endpoint, but the 58% of the ties were actually broken by overall mortality and cardiovascular-related hospitalization. And also there was a reduction, there was also all the key primary endpoints were met with 6-minute walking test, reduction, decline of the 6-minute walking test, KCCQ, difference in NT-proBNP and troponin as well. So we have seen what we can do is stabilize the protein. So both tafamidis and acoramidis, what they do, they bind to the protein and inhibit the misfolding. So they are called stabilizer. But we can also target the basic pathobiology of ATTR amyloidosis by going and reducing the production of the amyloid precursor protein, which is TTR. So we can reduce the production of the TTR amyloid precursor protein using gene silencers and using genome editing approaches. In the past, we used to use liver transplant in patients with hereditary ATTR amyloidosis, but this is not done anymore because we've got effective drug that can basically do exactly the same, but just as a kind of subcutaneous injection. So in terms of silencers, this was the first cardiomyopathy trial that was where the results were published, was the Apollo B trial testing patisiran given over infusion every 4 weeks, and it was a large global study in patients with ATTR cardiomyopathy. So it was a 12-month study, placebo control, and at 12 months the study met the primary endpoint with a reduction in the decline of the 6-minute walking test as compared to placebo. All other key primary endpoints were also met with a reduction in the decline of the KCCQ, difference in NT-proBNP and troponin. And these was a quite extraordinary results because in such a short period of time as 12 months, there was evidence of efficacy when patisiran was done compared to placebo. The second generation of patisiran, vutrisiran, is currently being tested in a large phase 3 global study in patients with ATTR amyloidosis, the HELIOS-B study. Hopefully, the readout of this study will be in the second or third quarter of next year. These two compounds were from an Alnylam company, and roughly at the same time, Ionis started a very similar program with silencers, which were using a slightly different mechanism, but still being able to significantly reduce the production of TTR amyloidosis, and this one is the large phase 3 global study in patients with ATTR cardiomyopathy. It's the Cardio-TTR Transform study using eplontersen against placebo, and probably the readout of this trial will be in 2025. But the field is trying really to go a step further, and instead of using just gene interference approaches, TTR amyloidosis has been the first disease in human where genome editing was ever done. This was done with NTLA-2001, which is an investigational CRISPR-Cas9 based technology. So it's a lipid nanoparticle with a single guide RNA and the mRNA of the Cas9 enzyme. And what happens is that after a single infusion, the lipid nanoparticle is rapidly transported to the liver, taken up by the LDL receptor. Then the Cas9 mRNA is translated to produce the Cas9 enzyme. Then this binds with the single guide RNA, and this complex is able to precise cleavage to edit the TTR gene permanently. And so this was an extremely important result, not only in the field of ATTR amyloidosis, but also because in 2021, this was the first time that genome editing was ever done in humans. These one are the results in 12 patients with ATTR cardiomyopathy, but now we've recruited more than 60 patients in this trial. And these results showed a deep and consistent and durable TTR reduction achieved above the 0.7 and 0.1 milligram per kilo doses in patients with ATTR cardiomyopathy. These are only the results of the phase 1 trial and very preliminary results, so the results of the expanded phase 1 are still awaited, and of course we will need to do a phase 3 to also demonstrate the long-term efficacy and safety profile of genome editing. But so you have seen how we can reduce the production of the amyloid precursor protein with gene interfering and genome editing approaches. We can stabilize the protein to inhibit the misfolding, but we can also now try to target the existing deposits and remove the existing deposits. We were very excited when we saw the publication of this phase 1 study, NI006. So these are monoclonal antibodies that were isolated from very early healthy individuals, and this was the phase 1 testing the initial safety and any sign of efficacy in patients with ATTR amyloidosis. They were able to show significant reduction in the extracellular volume measured by cardiac MRI, which is a measure of the cardiac amyloid burden, and this was also associated with a significant reduction in NT-proBNP level and troponin. These are very exciting results, and the phase 3 is going to start and open in the UK, hopefully the first quarter of 2024. Last compound that's currently being tested in phase 1. This one is a pan-amyloid antibody, so it's able to bind not only to ATTR but to all different types of amyloid, even the most rare type. The phase 1 is currently ongoing, and by using basically the same protein but labeled with radiotracer, they were able to show the highly specificity for all the different amyloid deposits with all the different types in all the different organs. Phase 1 is currently ongoing, expected to close recruitment in 12 months. The actually very last compound is NNC 1619-001. This one is from the Novo Nordisk company. Again, a monoclonal antibody directed against the existing deposits. Recruitment in this trial is probably going to end in 6 months, and the readout of the trial is going to be hopefully in 2025. But then how much can we really obtain when we target the existing amyloid deposits? Can we really lead to complete regression of the amyloid cardiomyopathy? These were 3 completely amazing cases we found during the clinical practice at the National Amyloidosis Center, where we saw that there was absolute and complete regression of the amyloid cardiomyopathy in the absence of any disease-modifying treatment. You can see this one was the first patient. You can see this one is 3 years apart. The wall thickness goes down, lega disappear, bone uptake disappears. This one is patient number 2, exactly the same. And this one is patient number 3, where you can see that the wall thickness goes down, there are changes, the voltage increases in the absence of pleural and pericardial effusion, and there are also changes on the diastole. What we had in the third patient was also a cardiac biopsy that showed extensive amyloid infiltration of macrophages with the multinucleated giant cells, which was basically eating up all the amyloid deposits. You can see the amyloid deposits inside the multinucleated giant cells. So what was happening on these 3 patients? It took 1.5 years for us to understand that these patients completely naturally develop anti-ATTR antibodies directed only against the misfolded form. So for complete pure chance, these patients were able to recognize the protein, produce antibody, get rid of the protein. But for us, this was extremely important because it was the first proof of concept that ATTR amyloidosis is a completely reversible condition. As long as we can find the right antibodies and we can deliver the right antibodies at the right level in all our patients, we will be able to completely reverse the condition. So there is a lot of hope in the 3 compounds that you have seen that target the existing deposits from Atralus, Novo Nordisk, and Neuroimmune AstraZeneca, because we really strongly believe that reducing the production is not enough, but the strategy where we combine production and existing deposits is really the way to go. What do we do in these patients in terms of standard heart failure treatment? In the past, we used to say that there was no role for standard heart failure treatment in patients with these conditions. Now we know that actually a low-dose beta blockers, if tolerated, could be useful in patients with an ejection fraction less than 40, and MRA are associated with a prognostic benefit and have got a good tolerability profile in patients with this condition. All of this is retrospective data, so there are no prospective data, but there are no clinical trial testing this drug in patients with these conditions, so probably this is the best that we have at present to guide our treatment approaches. There are also emerging data in SGLT2. SGLT2 inhibitors seems to be associated with prognostic benefit in patients with this condition, and the tolerability profile, again, is absolutely excellent. So in conclusion, cardiac ATTR amyloidosis is emerging as an underdiagnosed cause of heart failure, especially in the elderly. There are 2 main types of cardiac ATTR amyloidosis, wild type and hereditary, with different clinical phenotype and prognosis. Imaging has completely transformed our non-invasive diagnostic pathway, and this has led to an exponential increase in the diagnosis. The treatment landscape, as you have seen, is completely transforming, and probably in 5 years we're going to have different drugs able to act with different mechanisms that we will be able to use in combination. Thank you so much for your attention.
Okay, so I wonder if the 3 speakers could come up to the stage. Would that be okay? Rob and Kostas, do you want to? So we'll try and make up a little bit of time, but great talks, and I'm sure there'll be some questions from the audience. Okay, just while we're waiting. So Marianna, incredibly exciting for TTR amyloid, all these treatment options, but there's a lot of people with it, and they're sort of elderly and quite frail. How do we manage them across the country? How do you set up a network that means they don't all have to come up to London?
Yeah, absolutely. So we are working on the setup on a hub and spoke model, where which actually has been approved by NHS England after many years of requesting for funding to be delivered to set up such a model. It's not going to happen tomorrow. These things take time in the sense, but we now have the funding and the plan to actually proceed and developing this network of centres working across the UK.
Oh, that's great to hear. Yeah, Lima.
I wondered what your pickup was in those cases where they just presented with pure HCM and you did mitochondrial testing.
It's all right, Lima doesn't need a microphone.
Loud voice, yeah.
I'm not sure that we have that data. I suppose the group of, I mean, Kostas, you might have that, but I suppose the group of patients that would apply to is mainly those with the 4300 mutation, because they really don't have much else apart from the cardiomyopathy. Those are the ones you sort of don't want to miss. And I know probably previously, historically, that were on various panels, but now aren't. And so it might be that, in future, when Genomics England have developed a way of calling mitochondrial DNA variants accurately, because at the moment that doesn't really exist, and that's why they're not really appearing on lots of panels, through whole genome sequencing, that is. You know, it might be that we get a better understanding of that. I suppose it would be something that would be potentially interesting to look at, actually thinking in the 100,000 genomes, you know, to see how many people have the 4300 variant across all diseases, to really understand what the carrier rate is, because as I say, the penetrance is so variable. There are lots of people out there that probably don't have any clinical manifestations, so that would be one way of approaching that and answering that question. But as I say, the other mitochondrial diseases that have cardiac involvement, really, you know, if you look carefully, it's often quite obvious that there are other system involvement. There might be matrilineal inheritance. The 4300 is particularly difficult. It's just heart, and it has that variable penetrance.
So there's a question from online. So Rob, this is to you too. Could you comment on whether or not mitochondrial donation is an option for family planning? And if it is there an accessible service available?
Yeah, so that's a really good question, and I think it's particularly applicable again to the 4300 mutation. So at the moment, there are a number of reproductive options for mitochondrial diseases. Obviously, for nuclear DNA mitochondrial disease, it's all the usual options. So PGD, for instance, for mitochondrial DNA, there's egg donation, there's PGD, and that's what they do there is they're looking at embryos with the lowest level of mitochondrial DNA mutation to reimplant back into the uterus. And then mitochondrial donation is particularly aimed at those with homoplasmic mutations, because, you know, no matter what you do, you're going to end up with a homoplasmic mutation when you harvest embryos. So the 4300, I'm not aware whether it's been done yet, but that would be a good candidate. Others include Labour's hereditary optic neuropathy. And there is a national clinic for that based in Newcastle. So we refer our patients up to Newcastle to their reproductive options clinic for that procedure.
Yeah. Great. Jan.
Fantastic talks. Thank you very much. I guess this is for you, Kostas. You often see that pattern in mitochondrial problems of pre-excitation. How often do you think that's truly a pathway which an electrophysiologist can ablate? Because you don't often ever see AV re-entry tachycardia, do we? We see atrial rhythms and ventricular rhythms, but should I be taking them to the lab?
I think it's relatively low, isn't it? I mean, quite often you got this pre-excitation, this pseudo-normal, pseudo-excitation, if you want, where you see the short PR, and you don't even see a delta wave. But if you've got a proper delta wave and a Wolff-Parkinson-White, then I think you have to assume that it will behave as an accessory pathway, really. But you often see pseudo-short PR intervals quite often without actually a delta wave in this patient population.
So do you think that's related to the sudden cardiac death in those patients?
I mean, as I saw this, the rate of sudden death is really pretty low, and in our 600 patients, there were 5 sudden deaths, and 3 of them were related to conduction disease in patients not, having pacemaker for one, or not being recognized, or declining a pacemaker. So really, I think the other 2 patients, they had normal investigations at baseline, so I think it's pretty rare to assume that the Wolff-Parkinson-White. Then again, but if you've seen also the actual Wolff-Parkinson-White is pretty low as well as so we see that maybe in 2-3% of the patients, relatively low, really.
Gerry, I've got a couple more, just very briefly.
Go on.
So again, some questions from online. Marianna, is there an age cutoff for considering TTR amyloidosis treatment, particularly in the elderly? And is there a point in referring for biopsy if not eligible for treatment, i.e. patients more than 80 years of age?
Sorry, the biopsy, I didn't get the biopsy comment.
So for example, should you consider referring a patient for a biopsy if they are not eligible for treatment?
Yeah, so the first question is, unfortunately, all the studies, and of course driven by commercial interest, never investigated when is the time not to stop or not to give treatment. And these patients are patients with a lot of comorbidities. They're 85, and amyloidosis could just be not very dominant in their clinical phenotype. So I think that actually involving like geriatrics to understand the frailty of these patients, so have a global evaluation beyond what's the cardiac phenotype is extremely important. There are no frailty evaluation. When do we stop in terms of when the patient is too advanced? So there is a push to start treatment in all patients, never stop it. But I think as academics and clinicians, we need to focus on when the treatment is futile and when we shouldn't start or when we should stop. And the second question, completely agree. If the patient is not for treatment, we shouldn't do a biopsy. So sometimes we question, is it AL or TTR? And for TTR at present, we do not have treatment in England. And then so what we do is that unless they will go for chemotherapy, if it is AL, then we wouldn't go for treatment. So absolutely the biopsy has to be linked to, would change the management. Yeah.
Do you think everyone should be recruited into a clinical trial?
Pardon?
Do you think everyone should be recruited into a clinical trial?
I think everybody who fits the criteria definitely should. And so there are so many clinical trials, and also even when the families will be available, there will be all the trials targeting the existing deposits. So we should offer the option of combination treatment with patients on tafamidis or on patisiran and inotersen, and on trials which target the existing deposits.
Just one very final quick one. I'm sorry we're delaying lunch. Do you think we can develop an RNA vaccine for non-wild type amyloidosis, like that being done in the cancer vaccine launchpad?
Yeah, that's a super interesting topic, because this is a bit the direction of travel that the field is taking as well. Because these patients develop autoantibodies, so could we actually vaccinate these patients and make all patients produce antibodies, and so naturally enhance the immune system to do what the immune system should probably do and does in all patients who don't develop amyloidosis? So absolutely, yeah.
Thank you.
No more. Rachel,
Word from me.
Rachel, what time would you like us back? So it's
maybe if...
Yeah. Okay. And would that be for the clinical cases? Yeah. Okay. So if we all come back for 1:30 for the clinical case, and a big thank you for all our speakers. Wonderful session.